Might as well go to the beginning. I don't want to start in the middle. All right. So yeah, I've gathered that the theme for today is the extremes of life. That's sort of the theme for the talks. I joined at the end of the Jerry Delirium talk. So now we're going to go to the complete other end of the spectrum, and we're going to talk about management of febrile young infants. This talk, some of you have seen me give versions of this talk. Hopefully, certainly, I know that the residents, you guys all rotate with us, about once a year. So you've certainly seen these patients, and many of you will go on to work in general EDs. Some of your staff colleagues who are joining us right now probably also work in general EDs. So this is a ubiquitous topic, and it's a very, very common in pediatrics. As Robert mentioned, this is the area of my research interest, and I'm a clinician scientist here at the Children's. So I'll start by saying I have no financial disclosures, no conflict of interest. Only thing to disclose, I'm not wearing pants. What we're going to talk about is some learning objectives. We're going to have an initial review. We're going to talk about some of the historic risk stratification criteria for febrile young infants that have existed through the past decades. We're going to talk about some of the most recent lessons learned from large prospective cohort studies that have been coming out increasingly frequently in the last 5-6 years. Then we're going to talk about some large-scale quality improvement initiatives, and this will give everybody an idea of where febrile infant management is moving. And we're also going to hopefully, I'm going to be able to provide you with some practical resources to be able to provide best evidence care. Now, in different iterations of this talk, I often get this comment. My fellow ED docs will usually say to me, oh, so you're going to give a talk on the management of febrile infants. Well, can you just give me the main points? Everyone wants the Cole's Notes version. What we're going to talk about today is the important aspects, and particularly aspects that have been highlighted or changed in the last few years. The truth about management for febrile young infants is that there's a lot of moving parts. And when we think about any algorithm, disposition, diagnostic tests, treatments, there's actually a lot of evidence for almost every single branch point, more than you might imagine. And we're working out basically like a pre-printed order set and pathway here. And you'd be surprised when you actually have to write an algorithm. It turns out there's over 100 different options or pathways to go down. So this talk is in many ways should be familiar to many of you. But there's going to be some nuanced differences, and we're going to talk about what has changed. So I want to start there with a bit of an introduction about some of the way this subject matter is evolving. So classically, when we talked about febrile young infants, we talked about infants in the first 3 months of life, and that's often what is still referred to in textbooks. However, the literature has really moved in a direction of addressing febrile young infants and management in this age group, really among infants in the first 60 days of life. And that has been a focus of more recent studies. Also, classically, the traditional risk stratification criteria have looked at risk stratification of serious bacterial infections, or SBIs. And these, depending on which definitions you read, will always include the three of urinary tract infections, bacteremia, and meningitis. And really the oldest studies also include other skin and soft tissue infections, osteomyelitis, pneumonia. So this definition classically has been very heterogeneous. So more recently, it's much more common to find in the literature that we're discussing invasive bacterial infections, and limiting our risk stratification strategies. Like the holy grail really is looking for identifying those infants with bacteremia or meningitis. And so you see that urinary tract infections has it sort of has been removed from the area where most investigations are headed. So when you hear people talk about IBI, we're looking for a smaller set, but a more difficult set of infections to identify. So I usually start this talk with a clinical case, and I can't see anybody, so I will skip the polling part. But usually I ask to get a sense of where people situate themselves with a patient like this. And this patient is carefully selected and represents one of the most, one of the more controversial ages to deal with, where we see the most practice variation. So this is a very, very common presentation, and certainly residents rotating with us have seen this frequently in our ED. And this will take an example of a 35-day-old term infant who's previously well and has an episode of 38.3 rectal fever measured at home. The patient is a term infant with an unremarkable perinatal history and no infectious risk factors. They present to an outpatient pediatric clinic first, and on arrival, the baby is well appearing, well hydrated, found to be easily consolable, and other than, and all vital signs are within normal limits, and a repeat temperature check rectally reveals a temperature this time of 37.5. The baby is also congested, and there's a positive sick contact with a sibling who is runny nose, congested, and signs of a URI at home. So this is a carefully selected case because this is the second month of life, sort of the battleground month, where you see perhaps the highest levels of practice variation. And we're going to approach some of the aspects of this clinical case to highlight some of the nuance. So fever in young infants is a very common presentation. What you see here is the number of infants presenting to the Montreal Children's Hospital each year. And what you see in the tall dark bars are the number of infants that are evaluated. And there's a lot. It's about 30% of all infants in the third month of life that are presenting for fever. And the lower bars are those infants who are admitted. And what you see is that this represents about 13% of all admissions to the Montreal Children's Hospital from the ED. So this is a very common presentation, and it's also very resource intensive. So febrile young infants are obviously brought often, but what's going on sort of epidemiologically? Well, it turns out this is a very common problem, not just presenting to emergency departments, but obviously also to the outpatient setting. And 2% of all term infants born will present to some healthcare provider because of fever in the first 3 months of life. We talked about SBIs, and this is a graph of SBIs. And what we see is that there's approximately 10% of these patients with fever who will present a serious bacterial infection. Now, what you're looking at here is a graph from a paper in 2014. But whether you look at data from 2014 or going back as far as 1993, the reality is that although there has been an epidemiologic shift in the infectious etiology, there hasn't really been a change in the prevalence of this problem. So overall, we see that there's approximately 10% of all febrile young infants who will have a serious bacterial infection, with a peak in the first month of life where there are more infections. What you're looking at right here, by the way, sorry, is the proportion of infants with the various types of infections presented by week of life. And the next bar you see is the rate of UTIs, which is approximately 8% of the 10%. Down here, you have approximately 2% that will present bacteremia and about 0.5%. So fortunately, meningitis is rare, but of course it is devastating. So we have significant ongoing practice variation, and that's true both in Canada and the US. And several papers have shown that there's ongoing practice variation, even as recently as about 6 months ago, in a large cohort study published in the US by the PCARN group, so the same group that brought us the clinical decision rules for head trauma in children. Part of the reason that there is so much practice variation is probably explained by the fact that we don't have good recent guidelines. And in Canada, there was a management statement, a guideline put out by the Canadian Pediatrics Society, and that was put out in 1996. It was reaffirmed in 2012, and then after that seems to have completely vanished from the internet. Even if I could find it, I wouldn't use it. There's a lot of outdated information in that guideline from 2002, but there has never been any updates by the any updates or reaffirmations by the CPS since then. So this is a sort of historically very important slide or concept, and it basically relates to the management from the first ever large, let's say the first consensus guideline ever proposed. And this was proposed in 1993. It was reaffirmed in 2000. It was simultaneously published in Pediatrics and Annals of Emergency Medicine. And this was published by Larry Bariff. And this guideline has sort of set the tone for all of the normative approaches that have continued to propagate since then. So we're going to start with the first month of life. And what you see is that in the first month of life, all infants are to receive, they're recommended to receive a full septic workup, including a CBC with differential, blood cultures, a urine specimen for culture done by catheterization or suprapubic aspiration, chest x-ray if there are respiratory symptoms, stool microscopy if there's diarrhea, and then includes in our full septic workup, a lumbar puncture for CSF testing by culture, gram stain, count, and counts. So this is the template for what has really set the basis for our normative approaches in the under 1 month age, a full septic workup. Infants in the first month of life are then recommended to be admitted and started on parenteral antibiotics. I'm going to highlight something from this document that is a road less traveled. You don't see it as much, and studies that have looked at practice variation rarely show this course of action, but this same document does outline another option, and that is to admit infants who have undergone a full sepsis workup and to observe them without antibiotics. So this is rarely done, but does occur, and this is for the well-appearing infant with low-risk features on all of the initial full sepsis workup. As we talk about the second month of life, you'll see that there are several different published strategies, and a well-appearing low-risk infant in the second month of life meeting low-risk criteria can be managed either on an inpatient or outpatient basis. And there are various strategies depending on what your preferred guideline is. And all of them have shown to have good test characteristics and to be safe and effective. So the risk stratification criteria that we're largely referring to are the Boston, Rochester, and Philadelphia criteria. And what you see is that these were published as far back as 1993, and the most commonly utilized risk stratification criteria is the Rochester criteria. The Rochester criteria was actually derived in 1985 from just under 300 infants in total. It did not use sophisticated methodology or statistical methods. It was largely an observational constellation of clinical and lab findings, and that has actually emerged as the most salient risk stratification strategy. So the Rochester criteria, although published in 1994, has been widely used. And here you see a comparison of each of the three types, the three most common risk stratification strategies. Rochester criteria is here in the middle. And the reason Rochester has likely emerged as the most common is because it is the only one that was derived that included infants in the first month of life. You'll also notice some important differences between these risk stratification strategies, the most important of which is that the Rochester criteria does not inherently require a CSF sample. So you do not need to do a lumbar puncture if you are using a Rochester risk stratification criteria as it was put forward in 1993. So that strategy is the lesser chosen strategy. It's unusual, and we see that most studies looking at practice variation show LP rates above 90% in the first month of life. But in principle, the original Rochester criteria did not mandate the use of a lumbar puncture. What I'll highlight is that there are some subtle differences also in the cutoffs of a normal white cell count. They all perform with reasonably good sensitivity and negative predictive value, which is what you want. And what you see is that a low-risk infant, in principle, could be managed as an outpatient without antibiotic treatment as long as follow-up is arranged. So we'll talk a little more about the Rochester criteria because now we know more than we did then. Now, what's important to remember is that the Rochester criteria was derived for the detection of serious bacterial infections, SBIs, which are the majority of all of the bacterial infections among febrile young infants. But when you think about the fact that the majority of those infections are urinary tract infections, we have a test that works very well for the detection of urinary tract infections, and that is of course, the urinalysis. So given that we have that, what we really care about is the infants with bacteremia and meningitis. And what you see is that when we look more closely at the performance of the Rochester criteria for the infections that really matter to us, performance is actually not really adequate. So this is a large study published from it's a subset of the PCARN group, and this is called the Febrile Young Infant Research Collaborative. It's eight of the freestanding American pediatric emergency departments, and they looked at over 5,000 patients in a cohort study. What they found is approximately the usual reported rates of bacteremia and meningitis, and what they found was that when you look at Rochester's sensitivity and specificity for the detection of invasive bacterial infections, we see that the sensitivity is about 92%. What that means is that you can pretty reliably be missing 10% of the most important infections. And it performed a little better in the second month of life. But if you look at the ends of this confidence interval, you see that you can be missing as high as 20% of all of the most severely infected infants. What we also know is that the Rochester criteria have a reasonably heavy reliance on the CBC. And the white count is the only, let's say, universally used laboratory test of the Rochester criteria. So how well does that test perform for the infants with the most serious infections? Well, this is again from the same group. This is from the PCARN group, and it's 26 of the 36 freestanding pediatric emergency departments, and they looked at over 4,000 infants in the first 2 months of life. And what they found was that when we look at the white blood cell count, the median white blood cell count for infants who have an invasive bacterial infection was 10.7 compared to 9.6 among infants who don't have an invasive bacterial infection. So there's two problems with that number from where I stand. The first is that I can't tell those two numbers apart. Statistically, those numbers are the same. And more importantly, is that that number among the infected infants with invasive bacterial infections is well within the normal range for white blood cell counts. They also went on to show that they have low sensitivities at other common cut points that are considered to be high-risk cut points, like a white blood cell count below 5, above 15, or an abnormal ANC. So these have very, very low sensitivities. So this paper really showed the poor performance of the complete blood cell count as the only Rochester criteria blood marker. More recently, of course, there's been an expansion in the repertoire of tests that we have for this patient population. You see a lot of studies that have now looked at CRP, procalcitonin, even the risk stratifying effect of if you perform broad viral testing. And most recently, there are some, call them proof of concept papers, and this is still largely experimental, but looking at RNA biosignatures. So these are host responses that can distinguish between, so a single blood test that can look at an infected baby to determine whether the host response at a proteomic level, or I should say at an RNA and proteomic level, are showing responses to a viral pathogen or to a bacterial pathogen. And those are, as I said, now largely experimental still. But what we do know is that there are better tests available than the CBC. And any study that you look at, either retrospective, prospective, meta-analysis, the CRP and procalcitonin outperform the white cell count in all of them. This is one of the more recent studies, and it's one of the larger single studies that exist, other than going to the level of a meta-analysis, where you see the test characteristics of procalcitonin and CRP compared to complete blood cell count markers. So as a quick epidemiology reminder, what you're looking at down here in the bottom right corner is a receiver operator curve. And to give you a quick reminder, you're looking on the x-axis, on the y-axis is your sensitivity, and the and the x-axis is your 1 minus specificity. So what this means is that if you have a perfectly sensitive test, it is perfectly sensitive, so it's right up here, and a perfectly specific test, 1 minus 1.0 would be 0. So a perfect test lies right up here in the corner, and what you would see is it looks like the line has been dragged up to the corner. And a perfect test, you then calculate the area under the curve, and that is the amount of area in this rectangle, and a perfect test has an area under the curve of 100. Now, this line down the middle is flipping a coin, and that is a receiver operator curve or area under the curve of 50%, and that is flipping a coin. And when you think about tests that we have today, the highest performing tests in general are PCR tests, and they perform with sensitivities and specificities, both usually in the high 90s range. So those are pulled up here usually. And tests that we consider to be good tests, good diagnostic tests that aren't PCRs, tend to have receiver operator curves in about the 85% range ballpark. So let's see how these performed. It's pretty obvious what you're looking at, but basically this large study across 15 French pediatric emergency departments, they studied 2,000 infants, and you saw that and what you're seeing here is SBI. Your test characteristics for PCT and CRP were almost identical for SBIs, and those were in the 80 range. And you see that they both outperformed WBCs. That's also true for IBI, and PCT performed with test characteristics in the 90 range for the area under the curve. So that's a pretty good test. And no one is suggesting that it is a standalone test, but when incorporated into risk stratification algorithms, is certainly going to outperform white blood cell counts. And that has actually already been done. And so there's a group in Spain that derived what is called the step-by-step approach for management of febrile young infants. And the step-by-step approach was derived in about 2011. And this was a large validation study they published in 2016 at 7 centers across Europe, both in Spain and across the continent. What I'm pointing out here, and then there's another study that was published, a new risk stratification, again for serious bacterial infections, published again. This is by the PCARN group. And what I'm highlighting in these strategies is that they both have incorporated procalcitonin. They make use of CRP or the ANC, and they've both completely done away with looking at the white blood cell counts. So there's really been this move away from the Rochester strategy and using the CBC as the predominant blood marker for SBI and IBI. So I want to focus on a few modern lessons, because those two studies I just presented and the cohort studies that they looked at, also the other validation studies and other groups, have given us more information about febrile young infants in the past 6 years than we've had in the last 3 decades combined. So the first lesson, and I want to highlight these lessons because I think that these are common pitfalls, and we see this clinically among trainees. We know that this contributes to a lot of the practice variation, and it is particularly true in for patients presenting to the outpatient setting. So the first lesson I want to focus on is that fever is fever, and it basically only takes one. So once you have fever documented anywhere reliably, we know that that is an important marker for SBI. And very frequently, a patient will present to the emergency department and they no longer have fever. In fact, that occurs in approximately 50% of cases, and about 40% of cases never have fever recurrence whatsoever. And there's a single recorded spike that happens either at home or in a referring physician's office. So this study looked at this question, and this was what they asked the question: what is the risk of SBI in the first 2 months of life for infants who present with a history only of fever? So only on history, and this is from the PCARN group again. And what they found is that when they studied this near 4,000 infants in the first 2 months of life, the overall rate of SBI is, as we described previously, about 11.5%. And if you had fever when you presented to the ED, it was about 12.8%, compared to, let's say, 9% when you did not have a fever recurrence. So they found no differences in the rates of IBI. However, this difference in SBI was, in fact, statistically significant. However, the authors concluded that this small decrease in, or let's say clinically, statistically detectable, was not a meaningful, clinically important difference, and that it should not alter decisions regarding management. That is to say that if you never had fever again, you still basically have an SBI rate of approximately 10%. Like that's what we talk about. We talk about this average of about 10%. So, 10 versus 8.8%, that really shouldn't be changing your approach to management. So if they have a single fever at home, it's important to know that that might be our only clue to signal that this is an infant who is in fact infected with a bacterial pathogen. A similar study was performed by the same Spanish group and in their cohort, and they found similar numbers. This was about 2,500 infants, and they looked at the first 3 months of life, and they looked specifically at IBI. And again, I mentioned this, and why this is important is because this is really the harder to find group of infections, and they're the most clinically important infections. And what you saw is that among infants who presented who were febrile on presentation, there was a 2.4% risk or prevalence of IBI. And when they were afebrile, it was identical. So when it comes to a SBI, there is maybe a statistically lower number, but that is not clinically meaningful. When it comes to IBI, there's probably no difference at all. The second lesson I want to point out that is a common pitfall, highlighted also in our case that I presented at the beginning, is that this is often an infant presenting who's runny nose, positive stick contacts. It is a very common knee-jerk reaction to say, hey, this kid has a cold. Isn't it just a cold? That's just a virus. There's nothing really more to do, right? Well, probably that is not correct. And the reason why I say that is because there's been a few studies now that have looked at this. And we know that when we have documented viral illnesses, it is an important risk stratifying feature, but probably does not obviate the need for a workup. And so this was a study that came from the PCARN group in 2018. And it's their same cohort, so 4,500 infants in the first 2 months of life. And what they looked at was infants who were proven virus negative and those proven virus positive. And what they found was that you have about roughly a 4-fold difference across all infection types. So if you have no virus, you're probably at 4-fold higher risk. And that is to say that when you have no detectable virus, you're sitting at about that 10 to 12% risk of SBI compared to infants who have a confirmed, laboratory confirmed virus. What they found was it was not statistically significant, but even meningitis was about twofold lower in infants who had viral infections. So in this paper, the authors concluded that although you have a important risk stratifying effect of viral illnesses, there is still a near 4% risk of serious bacterial infection. And then once again, this should not alter our decisions in management. Not only that, is that when an infant presents, we do not know what viral etiology they have, even if we assume they do have a cold, and even if we acknowledge they are probably at some lower risk. Well, the problem is that not all viruses were created equal. And this was a study that looked at viruses by type. And what they found in this large American study performed again it's a derivative of the PCARN group, it's 11,000 infants. And they found that for our given roughly 10% SBI rate, if you had rhinovirus, there was no difference compared to the overall rate of SBI. That is to say that the rhinovirus family did not confer the same risk lowering potential that the other detected viruses did. And that is when they looked at any virus that was not rhinovirus did seem to have the same risk lowering potential. So what that means is that we don't know what virus we're looking at when we see them. And even if we know that it is a non-rhinovirus, they still have it is a non-trivial and a non-zero risk for serious bacterial infection. So the last thing I want to talk about is, and to leave you with, is a practical tool that can be useful. And we're going to talk about clinical decision aids. Now, clinical decision tools exist in the form of guidelines, pathways, order sets, and the like. And the idea is that they incorporate best evidence to improve the quality of care. And there have been several large studies now that have come out. And for starters, some form of clinical decision tool is available in a majority of freestanding Canadian and American pediatric emergency departments. And these are used more widely in pediatric emergency departments than they are in general EDs, but I would recommend that probably will change. And in the US, it has already started to change. So this was one of the first large-scale quality initiatives with fairly widespread uptake after publication, but they instituted a quality initiative across the state of Utah. And they published in 2012, and essentially what they did is they showed that there was, using this statewide clinical decision care process model, they were able to decrease variation in care, improve quality metrics. What I'm showing here is the average reduction in cost per admitted patient by following this care process model with excellent clinical outcomes and no missed SBIs. What they published was a clinical pathway for decision-making in the ED, and this actually goes on to show it's an integrated ED and inpatient pathway. So then decisions regarding admission, duration, antibiotic choices, and it's a full algorithm from door to discharge that incorporates both the ED and inpatient care. They're not the only one. If you Google Children's Hospital of Philadelphia, or CHOP, CHOP is one of the leading pediatric hospitals in North America, they also have a publicly available algorithm. And this algorithm is for treatment of infants in the first 2 months of life, and that is publicly available. What they did is this was part of a quality initiative to increase the appropriateness of lumbar puncture performance. And basically they wanted to be reducing unnecessary lumbar punctures, and they achieved an impressive and sustained appropriateness for LPs. I want to focus now though on the largest quality initiative to date for this group of patients. In fact, this is the largest ever quality initiative endorsed by the American Academy of Pediatrics, and this is called the REVISE project, and it's called Reducing Excessive Variability in Infant Sepsis Evaluation, and it took place across 124 freestanding hospitals in the US, and this was made up of teams of ED and inpatient teams, and 124 is about a third of all US hospitals that participated in this quality initiative, which is very impressive as far as a quality initiative goes, or that type of initiative. This is a mix of academic institutions, rural, urban, so teaching, non-teaching, pediatric specific centers, general EDs, and you see that there's a broad distribution across the US, and one center also in Cameroon, actually. So they looked at a 2-year study period, and they have now published on their experience with this. And the first 20,000 infants had gone through this, through their quality initiative. They set out with very specific metrics, and what they intended to do was decrease unnecessary admissions, decrease variation in care, decrease length of stay, and decrease unnecessary tests. And they have very specific hospitalization targets. They developed for this project clinical algorithms that were best evidence, and they developed clinical decision tools that were widely available. The purpose of which was to, as I mentioned, see a sustained change. Here you see some of the data from that study, and this is an interrupted time series that shows over time rates of, and if on your left you're looking at the appropriateness of admission, and then you're seeing meeting the criteria of appropriate length of stay. And they had sustained increases of 10% better appropriate hospitalizations. They had a 76% increase in appropriate length of stay once brought to hospital. That includes both ED and inpatient. And they had no change in delayed diagnosis and no missed SBIs. So it's a pretty impressive quality initiative. For that initiative, they developed all kinds of clinical decision tools. And what I want to draw your attention to is the app that they developed. And the app is freely available from the Apple or the iTunes store. And it's available for iPhone and Android, and it's called Peds Guide. And Peds Guide, it actually is not only febrile infants, it also has resus, and it also has, at the moment, asthma as well. And they're working on others to add to this app. But basically, it walks you through the steps for management. And if you use it, it would probably today represent a safe and reasonable medical legal choice. and you will find that it has some roots in the Rochester criteria. It does still make use of a normal white blood cell count. However, it does incorporate PCT and CRP. It also gives the recommendations for treatment and disposition built right into the app. So if we come back to this clinical case, it highlights some of the points that I had wanted to make and the lessons that we've learned from these new recent studies. And the practical takeaways that I want to leave you with is that fever is still very common, and it's about 2% of all term infants. The SBI rate hasn't changed. It's still hovering around 10%, and that IBIs, unfortunately, are still hovering around 2%. There is ongoing significant practice variation, and unfortunately, still no national guidelines here or in the US. And unfortunately, we are unable to distinguish infants with serious bacterial infections on the basis of history and physical exam alone. A single episode of documented fever is all it takes, and this doesn't significantly change the proportion of infants who will have SBI. We know that that risk is not negligible, even when we have the detection of a laboratory confirmed viral illness, and that not all viruses were created equally. We know that there are now existing newer risk stratifications based on newer diagnostic tests, and largely moved away from using the white count as your risk stratifying lab test, and that there are excellent infant outcomes when using evidence-based approaches that are now widely available. And I'd recommend their use because they are medical legally defensible, and they are safe. And I would welcome any of your questions.
Awesome, thank you, Dr. Burstein. At the moment, we just have one question in the chat.
Sure.
This is from Nicholas Zelt. He says, I'd read that 97% of bacteria cultures will return positive if destined to within 36 hours. How long do you recommend observing before declaring a negative workup in a well-appearing infant, given the false
Sorry, Robert, you clipped out for a second. I didn't hear you. You said 97%, yeah?
So blood cultures which are due to be positive, 97% of them are positive within 36 hours. So how long do you think we should be waiting to consider a child clear?
Okay, so there's two issues that you're addressing with this question. There's two facets to this question. The first is false positive rate, okay? So false positive rate, you're very right, it's not trivial. In fact, in the pediatric and let's say young adult age group, I caution anyone that does a blood culture, it's not benign, nothing we do is benign. And I presented data showing blood cultures positive at a rate of about 1.5%. As you can imagine, in older, vaccinated, healthy children and young adults, that rate is well below 0.5%. And here at the Montreal Children's Hospital, we have a 2.5% rate of false positive blood culture. That's approximately 4 times higher. And I'm talking about not in the febrile young infant age, but across all age groups. You're 4 times more likely to have a contaminant, false positive, than you are to have a real positive blood culture. And I don't mean a child who presents and they appear to be in septic shock. I'm talking about a well-appearing, vaccinated, immunocompetent, previously healthy child or young adult. So that issue of false positive blood culture is not trivial. And of course, as you know, there is downstream important consequences. It's a family that's going to be called. They are going to come back for treatment and reculture and presumptive bacteremia. So that's a very good point you raised. That's the first part. The second facet to what you're discussing is the duration to antibiotic positivity, blood culture positivity. Several publications on this subject. And what we know is that, I'll take the share off. What we know is that it's approximately 92 to 94% that can be captured within the first 18 hours of true positives. And that number goes up to about 96 to 98% within the first 24 hours, within the first 36 hours. So you really will be capturing almost all of them. There's a study from 2020, it's about a month old, where they looked at specifically CSF cultures. Real CSF cultures were growing within 18 hours. Contaminants were closer to 36 hours. And there was a significant difference between them. Several studies, one of the first ones to look at this was published in JAMA Pediatrics in 2016 by a guy named Eric Biondi. He's actually the leader of the AAP quality initiative there. And they have very similar numbers. You know that you're capturing about 95%, certainly within under 24 hours. So we're having this conversation about duration for hospitalization. I personally, we've incorporated this into our algorithm. I would just make the comment, this is clearly not an emerge question, right? So this is because I collaborate with inpatients and we need to decide the total door to discharge strategy. And that is why we've looked at it so carefully. But largely it's beyond the scope of an ED physician's workup usually. But generally you can reliably, so I guess I'll leave you with this, call it on the order of 95% will be known in 24 hours. And it's almost that same number, 92, 93% in 18 hours. So that's the long answer to something that doesn't affect most of us.
There's another question from
Yeah.
Audrey. Are you able to see the chat or shall I read it out?
I'm seeing it now. So how are you communicating this with parents? Are you telling parents a congested afebrile kid that the risk of SVI is 4% and that you recommend going ahead with investigations? Do you use the number or do you suggest investigations to parents? I find it difficult to communicate the level of risk when kids look so well. This is a great question. So very little studies. So a large part of my research program is the incorporation, safely incorporating shared decision making. Okay, so that's you are touching on that facet. And this is a complicated issue. There's very little data. We know that the whole process does have iatrogenic risk. We know that it is certainly uncomfortable. It is anxiety provoking. Parents have largely, none of the recommendations and none of the guidelines I showed you said, ask parents. Okay, like 30 years ago, that wasn't even a concept. So in the paternalistic model, we would just propose, we would do those things. In the US, there have been interesting papers written and they're called like ethics rounds, things like that. If a family presents with a child, I'm just going to give you an example, with a treatable form of pediatric cancer in their 2-year-old, and there's a 95% cure rate, and they say, no thanks, we choose not to treat. It's a clear example that the state would intervene and you would have a ethics or child protection intervention, and you would treat this child and you would err on the side of life. And that is a case where it is the risk of death is certain and the cure rate is near certain. Here you get into a bigger gray zone. However, in the US, for example, this is still grounds for child protection intervention. And there are ethicists that have written on this because you have a 10% rate of something that is potentially fatal with a perfect cure rate. Now, it's not perfect. It's not 100% cause of death, but this is still, and again, the US is a different medical legal climate. So what I'm getting at is that there's not really much of an option in the US. It's not that there's an option presented to families. The subject of shared decision-making is emerging, particularly when there is more equipoise. The thing is, 4% risk of something that's potentially life-threatening is very high. When you ask me how I communicate this with parents, I usually tell them before we start investigations, all of these infections in children are different than in neonates are different than in children and adults. When we talk about urinary tract infection, which most parents can conceive of, they understand that idea. I tell them infants in the first 3 months of life don't have completely developed immune systems, and they can't contain that infection to their urine alone. And it often spills over to become a blood infection. And that is why it is so dangerous. When we talk about meningitis, we talk about how fortunately, it is rare, but it is very severe. And that we can't risk missing any cases. And this is how I usually lay out this discussion. I also usually make this parallel. I usually say, when the stakes are very high, we are very risk averse. And if I told you you had an opportunity to win the lottery at 1%, would you buy a ticket? And the answer is, you most certainly would. Nobody has a 1% chance of winning the lottery. So when the stakes are very, very high, 1% risk of a very serious outcome is important. And when you're dealing with a neonate, most parents understand that. It is not as medical legally contentious here as it is in the US, but that is how I present it. And I don't usually say, I tell families outright, overall, there's a 10% chance of serious infection. That is what I tell them. I don't usually get into 4% if you have a runny nose, because I don't know what virus the baby carries, even if they have one. If they have the ubiquitously present rhinovirus, the risk is the same. So I don't usually get into the subtlety of 4% versus 10. And by and large, the answer really is 10. So I usually say it's about a 10% risk. I personally do get into those kinds of numbers about, look, most of them are urine infections, but the other ones we can't detect as well. And yes, I highly recommend, I more than highly recommend this, this course of action. Now, what we're studying right now is how involved do parents even want to be in this discussion? To be totally honest with you, those of you who have been in the children's hospital, yes, most patients and families are very alarmed when they hear what has to happen for their children. But most come to hospital because they've been told by the birthing center or 811 that it's a medical emergency. So they have some expectation about what is necessary, but perhaps not the entire scope of what is necessary, particularly lumbar puncture and admission. What we have also started to find in our surveys of families is that many don't want to be involved, interestingly, don't want to be involved in the decision-making process. Many are sleep deprived and very anxious and say, tell me what we should do. More than other decision-making junctures, I find in life. When dealing with a neonate, parents tend to be more, they've demonstrated that they're more hands-off than when dealing with their own health or even the health of an older child or an elderly person. So I do go through percentages in general. I tell them that this is standard. We here at the Children's have developed a handout for families to explain what to expect. And that also is very empowering. When families see, if you have a handout, it's because it's common. And I tell them that it's a very, very common problem. And that's how we go about it. As you sort of saw in the algorithm, the second month of life, we all start with a partial septic workup. I tell them that it's possible, but we don't jump to LP right away, of course. And parents are usually very understanding. In the first month of life, they don't want to take any chances. By the second month of life, you can tell them, look, in the first month we start and do everything, and we go in a stepwise approach. And that is how I approach this conversation with families.
I have a quick question about
Sure.
just touched on, especially with the app. I love it. I've been using it for a couple of years since it was suggested to me. I noticed in the children's protocol versus the app, there's a designation between like first week of life versus first month of life.
Yeah, so we don't do that. That's right.
Yeah, why is that?
Okay, so the majority of studies that exist include infants that are 0 to 90 days or 0 to 60 days, and there's no distinction. So when you look at the data doesn't differentiate between them. In the US, when they rolled this out, it's very interesting. If you take a look, you'll notice, harking back to the Rochester strategy, once you are in the let's say second, third, and fourth weeks of life. Okay, so if you are 8 to 29 to 28 days in this app, you do not, it actually advises that you don't need to perform an LP. Okay. What they did is they built the safety mechanism in to not let that happen in the first 6 days. And you're performing a full septic workup in the first 6 days of life. So that is the reason. If you look at when they came to develop this, there were already several institution specific, like what we have, clinical practice guidelines at institutions that of all the participating institutions. And this was a big cultural change to go from everyone's getting, all of those institutional guidelines said LP in the first month of life. But as they wanted to try and reduce unnecessary LPs, go back to a system that is decent, especially if you augment it with PCT and CRP, they didn't feel they wanted to take that chance going to the youngest infants. Some data suggests that those infants, one of the main differences and what separates them, and it's somewhat academic, is that you also have early onset sepsis. So basically the NICU problem, okay? So You have your NICU infections still in that age group. They're considered at marginally higher risk. Most studies don't differentiate them. They just deal with the first and second month of life. So the data doesn't actually parse it out. It is highly theoretical. And there's also that, let's call it a graded approach to a major cultural shift. Rather than abolishing all LPs in the first month of life, it was what would be palatable, given that you had at the time existing institutional guidelines like ours that says LP in the first month of life. It wasn't really that palatable to all the stakeholders at all of these institutions, not to mention the anecdotal increased risk of early onset sepsis in the first week of life. Now, again, that definition is highly academic. And the reason for that, if you look at all studies of bacteremia and sepsis, bacteremia and meningitis, GBS sepsis, and that's really what we're talking about, the early onset sepsis. GBS sepsis actually presents in a range of 0 to 90 days, like the whole age group that is studied, it's always present. And most infections that aren't in the first week are postnatally acquired. Even if a patient receives perinatal antibiotic prophylaxis at the time of birth, we know that there's recolonization and you can have transmission postnatally. So at all ages here, you can still acquire GBS sepsis. So it's so academic, this notion that the first 6 days are higher risk. So if you're using the app, that's one thing you'll notice. And there's some subtleties in this app, but if you follow it, it's going to be medical legally defensible. It might not be the choice we make here at the Children's, and our institutional guideline, as you point out, is a bit different. One more thing I'll point out, actually, just that since most of you are MUHC based, an interesting thing happened on May 28th of this year. Procalcitonin was centralized at the MUHC, and it used to be done at the Jewish, and it was never available in a reasonable turnaround time for pediatric indications. So we started incorporating it into, and it now we're finalizing our post-COVID guideline or COVID and going forward guideline for febrile infant management. And we've included PCT, and we've done away with WBC, just to say, as our marker. And so PCT is available for anyone who is using it, anyone at the MUHC who wants to have it and incorporate it into their strategy.
Excellent, thank you. I don't think we have any more questions. Yeah, okay. Thanks again, Dr. Burstein. That was fantastic.
All right, thanks guys. Thanks for having me. I appreciate it. Take care.
Okay, before everyone leaves, just a couple of announcements. Next week was due to be our retreat. Sadly, it's not going to happen, but we are going to try and do some of the things that we usually do at retreat will be on Zoom. So we're going to have the R1 rounds of their life so we can learn a bit about them. And then we're also going to be doing annual town hall. Audrey has just dropped a link to the town hall survey. So if all the residents can try and fill that out by next week, that would be great. Okay, thank you everyone. Goodbye.